Hello, everybody, and welcome to our webinar. My name is Alessandra, and I work for the Humanitarian Leadership Academy. And it's a pleasure for me now to introduce you briefly to Alexandra and Nada, who will be presenting on health and nutrition in emergencies today. So Alexandra Rutishauser-Perera is a nurse with a diploma in tropical medicine and a master in nutrition. She's been working in public health nutrition for the last 11 years. 4 different NGO and across 15 countries. She's currently the head of nutrition for Action Against Hunger. Nada Abdelmagid is a medical doctor with a master in epidemiology. She has spent the last 7 years working in program design, delivery, and evaluation of public health interventions in difficult and insecure settings. She's currently working as an independent consultant in humanitarian health. So I'm now leaving the floor to Alexandra. Enjoy the webinar.
Hi, everyone. So just share my screen with you. So Nada and I today will take you a little on a route to our experience in emergency. And we have some objectives that we would like to get from this webinar. So first, we really would like to understand after this webinar, what are the key nutritional and health issues to consider during an emergency, but also what are the key lessons learned and any practical advice that we think you can use for the current crisis as well. Before we start talking about health and nutrition in emergencies, we thought it would be important to define also what is an emergency. And ICRC actually has a very good definition of what an emergency is. They define it as an extreme disruption that causes widespread human, material, but also environmental losses that exceed the ability of the affected society to cope using only its own resources. And there are really some keywords to consider here for you. And the fact that we are not only talking about human loss, but also material, and the fact that the government or the society have difficulties to cope with the situation. There is also another way to classify emergencies. And of course, you will look at the cause of the emergency, but you also need to consider if the emergency is a slow or a rapid onset, as well as if the emergency was caused naturally, or is it a man-made emergency? So for example, the earthquake in Nepal in 2014 was definitely a rapid onset emergency caused by natural disaster, which is not the case for a terrorist attack, which is still a rapid onset, but definitely man-made. And on the opposite, you have the drought, like what is happening now in the Horn of Africa, which is more of a slow onset emergency from natural causes, although now with the current issue of global warming, you might still want to consider also the man-made effects on the drought. And then a war, for example, what is happening in Syria and Yemen right now, would still be considered as a slow onset because deaths are not occurring immediately, but definitely a man-made emergency. So we will send you a new poll before the next slide. So do you think that women and children are up to 14 times more likely than men to die in a sudden onset disaster? Is it true or false? We give you 30 seconds for it. And that, what do you think? Okay, well done. Do I have to teach you anything today? So the other second important thing that Nada and I wanted to find before we talk about the intervention needed are throwing at you some facts and some data about the need for health and nutrition in emergencies, so that you understand better who are the person who need the most humanitarian intervention in an emergency. So, sorry, I'm struggling with the arrows. So, for example, one thing you need to know is that 250 million children right now under the age of 5 live in countries affected by armed conflict. And this is a case, for example, for Yemen and Syria, which are current crises that immediately comes to your mind when you think of children affected by war. It's also important to know that women, children, and adolescents are also facing an increased risk of morbidity, sexual violence, and depression in an emergency. Sorry, I'm having some technical issues with the slide. Yes. Some of the facts that you need to know as well is that in 2015 only, 2 in 3 maternal deaths occurred in an emergency. You were right in thinking that women and children are more at risk and more likely to die during an emergency, and they are indeed 14 times more likely to die than men during an emergency. And it's also very important for you to know that 80% of the high mortality countries have suffered either a recent conflict or a recurring natural disaster. And that's why, for example, 10 countries with the highest maternal mortality ratios are all affected by war or were affected by war. So take Sierra Leone, for example, which is the country in the world with the highest maternal mortality ratio. Well, Sierra Leone has been devastated by war for decades and is still trying to recover from it. The second country with a high mortality ratio, maternal mortality ratio, would be Central African Republic, affected by crisis and a war, Chad, Nigeria, followed by South Sudan and Somalia. So knowing those facts and those data, you understand very quickly that when you want to intervene in an emergency in health and nutrition, you really need to think of the woman, you need to think of the children, and you need to think of the adolescents. Then how are health and nutrition affected by emergencies? So there are definitely some direct effects of some emergency. Again, think of the current crisis in Yemen and Syria. We directly have death injuries from violence and accidents occurring. But there are also current crises where you have an indirect effect of the emergency with an increased rate of infectious disease or malnutrition. And here I'm thinking, for example, of Somalia or Ethiopia, where you might not have people directly dying from violence right now, but where the fact that the system is so weak that people are dying more of infectious diseases and malnutrition, and children being the most vulnerable to it. And of course, all of this is aggravated by a series of conditions that increases the number of infection, increases the balance of malnutrition, therefore increases deaths. So inadequate quantity and quality of water, poor sanitation, inadequate care practices is also a very important one, very often forgotten. Women, for example, due to a crisis, will have more difficulties to find a shelter place to breastfeed children, and we need to support them with that. Inadequate shelter, and all of this, once again, created by lack of security, food insecurity, the fact that supply chains are not working either. So knowing this, when do we know that a humanitarian response is needed? Well, very often it's triggered by the fact that there is an excess mortality and an excess so mortality is what we qualify as death, and morbidity is related to illness. So when we know that there is this increase, then we know that there is a need for humanitarian response. And it can happen very fast in the emergency and in the crisis if we know that it's a rapid onset emergency. So knowing our aim, we know that what we will act on to prevent excess deaths are trying to prevent malnutrition, trying to prevent infectious disease, reproductive and newborn illnesses, and also in some contexts, because HIV is also creating preventable excess deaths, we will also intervene on HIV. So really here, the role of the humanitarian response is to provide access to food, healthcare, and maintain an adequate nutritional status, because they are critical determinants of people's survival in an emergency. Nada?
Thank you very much, Alex. Good afternoon, good morning, and good evening to all of the attendants joining us from around the world. So moving from the background that Alex gave and looking at the public health priorities in emergencies, we now looked at some of the factors that affect the health and nutrition status and which groups are vulnerable. And on the basis of these factors, that nutrition, there are a number of priority interventions that are needed to prevent excess illness and excess deaths in an emergency. The first ones to look at are shelter, food, water, sanitation, and waste disposal. Now, these 5 priorities have universal and minimum standards to guide the response. For example, we know that at a very minimum, a person needs 15 liters per person per day of clean water for drinking, cooking, and personal hygiene. This is a universal standard anywhere in the world. On the other hand, for shelter, we know that at a minimum, we need an initial covered floor area of 3.5 square meters per person of shelter. Now, apart from the minimum standards, these priorities don't look like health priorities, nutrition priorities, but in fact, they have a direct impact on the health and nutrition outcomes of people in a population. So you safeguard people's health by providing a good shelter, nutritious and sufficient food, clean water, sanitation, and waste disposal. Now, the other public health priorities we'd like to introduce today are vaccination, supporting health facilities and clinics, preparing and responding to outbreaks, controlling disease vectors such as mosquitoes, which transmit malaria and yellow fever and other illnesses, and also the health, nutrition, education, and promotion. So these second set of priorities do have minimum standards, but many times they require adaptation to the local context. So for example, in Syria, looking at the vaccination example, in Syria, there was a polio outbreak in 2013, and it led to a series of up to 12 or 13 mass vaccination campaigns with polio. While in South Sudan, recurrent measles outbreaks led to several measles vaccination campaigns. So while vaccination was needed in both emergencies, the prioritization of which vaccine to give, how to administer it, and so on requires adaptation to the local context. Another example looking at vector control. In South Sudan, malaria is quite a common cause of illness and death, and we know that malaria is transmitted by mosquitoes. While in Syria, we have skin leishmaniasis, which is a disease that is transmitted by sandflies. And so while we do vector control activities in both emergencies in both countries, the type of vector we want to control and the approaches we take to control these vectors are actually quite different. So overall, these 10 priorities are not listed here in order, and the order of the priority of these interventions changes with time and across different phases of an emergency. For example, if we want to promote hand washing, which is under point 10 here on the slide, it's actually quite useless if people don't have access to clean water, which is under point 3. So it's important to look at them as flexible, and the priorities would change across different emergencies and different phases of an emergency. And obviously also in the slide, it shows us the importance of coordinating and working with other sectors as health and nutrition actors not all the health and nutrition status of the population sits with these activities. It sits with other sectors like shelter, like wash or water supply and sanitation provision, and so on. Next, please, Alex. So now let's look at some of the health interventions that are carried out under the health sector in emergencies. Let's look at some of the preventive interventions. And when we say preventive, we mean the interventions that aim to reduce the risk, to reduce the exposure of people to disease. So for example, vaccination is quite a common activity that we see in many emergencies. And it could be routine vaccinations provided in a clinic on a day-to-day basis, or in the form of mass campaigns to cover large numbers in the population. And they prevent against diseases like measles, like polio, like whooping cough, which could result in outbreaks in emergencies. Another type of preventive intervention is distribution of kits. For example, distribution of bed nets to prevent malaria, distribution of newborn kits, which contains essential items for a new mother to look after her newborn at home in an optimal manner. Other interventions for preventive ones include disease surveillance, so looking out for keeping track of infectious diseases that could result in an outbreak and monitoring the caseload and the numbers of cases we're seeing, but also preparing specific outbreaks and emergencies. And finally, education and promotion across the affected population, and this could cover a variety of topics. So it depends on the causes of death, the problems that you're seeing in the community. Next. Next, please. The other types of interventions we carry out in emergencies are curative interventions, and those aim to reduce disability or death among people who are already ill or unwell. And for example, these include setting up or supporting health facilities. They could be, I'm sure some of you have seen mobile clinics, or they could be fixed clinics. And also for those who are very unwell and require treatment at a hospital level, we support referral systems that make sure people get there in a timely manner. And also in the event of an outbreak, carrying out case management. And in many situations, those cases are not managed in the same clinics that would be present in a community. For example, in cholera, you would set up a separate cholera treatment just to treat cholera cases. And finally, in some situations, we have specialist treatment programs, such as treatment of tuberculosis, treatment of HIV, treatment of sexual violence or rape, mental health. In many cases, they're integrated to existing or they're set up as a parallel service. Next, please, Alex. Overall, whenever you have an emergency and you've identified your priorities, when you're developing your strategy, it's very important to try and strike a balance between curative and preventive interventions. You need both of them to make a strategy effective. For example, in outbreaks, it's important to monitor, to look out for an outbreak in advance, but also if an outbreak happens, you have the capacity to respond to it. So it's important to strike a balance between both of them in your strategy. And of course, it's also important to coordinate with other sectors, as we mentioned earlier. I'll hand over to Jem now, because I think we have another poll coming up before we go back to Alexandra.
So now that you know more about the health interventions, and Nada did clarify that you should integrate with other intervention, and what best sector to integrate health with than nutrition. So on the right side of the slide, you see the most common interventions in nutrition in emergencies that aim really at mostly treating acute malnutrition. So on the real right side in blue, you see the treatment of severe acute malnutrition is one of the most common activity in nutrition in emergencies, followed by treating the moderate acute malnutrition with the targeted supplementary feeding. And then also preventing this acute malnutrition by doing blanket supplementary feeding. So basically doing blanket distribution of food to what we consider the most vulnerable group for malnutrition. So very often this blanket distribution aimed at children under 2 or pregnant and lactating women or children under 5. And actually, you will see more and more this blanket distribution of food being through cash transfer rather than food. And then on the left side of the slide, you see all the interventions aiming at preventing malnutrition. So general food distribution, which is in this case providing food, but to the whole patient, to the whole family and the household. Infant and young child feeding interventions, so all the intervention aiming preventing nutrition in children under 2. All the intervention addressing underlying causes of undernutrition, so BWASH, water and sanitation, food security intervention, livelihood, mental health as well, very, very important and often forgotten. And finally, another common nutrition intervention would be the one addressing micronutrients. But really one you will see the most in an emergency are the one aiming at treating acute malnutrition and the one aiming at preventing acute malnutrition in children under. So talking a little bit more about the treatment of acute malnutrition and the scenario, the first thing that you will do in an emergency, even before waiting to have any nutrition product in country, even waiting before having all your staff in place and trained, would be screening children and screening them in their household to have a better idea of the children that are affected by acute malnutrition. And even before you have the treatment in place, you can still identify them and come back to them once you have the treatment in place. You will screen them with different methods. One is easier than the others, which is measuring the mid-upper arm circumference, but you will also measure them through their weight and height. And then you will have 2 different cases in front of you. The cases with medical complications. Most often you will see cases of severe pneumonia, dehydration, severe acute diarrhea, and those ones with complication will definitely need to be, at least for a short period of time, in an inpatient care facility. The one without complication, but still with severe acute malnutrition, they can actually be treated at outpatient. They only need to come to the facility every week instead of being in a facility on a 24-hour basis. And then still without complication, you will have cases who are not that severely acutely malnourished. They are moderate. And those ones would be treated with supplementary feeding. And then you will have the healthy children. But those healthy children needs to be screened regularly because they are really, really at risk of becoming moderately or acutely malnourished later on. So just to show you some images of what's happening on the field, this is, for example, a blanket distribution of food for children under 2 and pregnant and lactating women. This is what an outreach center could look like in Ethiopia to treat children who are severely acutely malnourished without complication. But you could also have them in health facilities and just strengthen the health facilities. Here on this picture, you have a child having ready-to-use therapeutic food, which is the treatment we provide for severe acute malnutrition. And finally, one of the most common way of screening children for acute malnutrition, one of the easiest one that we use more and more with mothers and families, which is measuring the mid-arm circumference of the children. So we'll ask you a new question on our poll and test your knowledge. So this is according to the Lancet series 2008. Which one do you think is the most effective intervention to prevent death among children under 5? Suspense. And thank you. I think you were a little bit biased by the fact that you are in the middle of the nutrition slide, but well done. It is indeed breastfeeding and complementary feeding. So in emergency, you will also see intervention aiming at promoting and supporting infant and young child feeding. And there are really 4 big pillars for this intervention, which is 1, supporting the mothers to breastfeed their children within 1 hour after birth. It's the best way to decrease neonatal mortality because you give a boost of vitamin A and antibodies to the children from birth. The second one is supporting the mothers to exclusively breastfeed up to the age of 6 months, because once again, it's the best prevention for infectious disease for the children, among all the other advantages of it. Then you will also have the mother to continue breastfeeding up to 2 years and beyond. And of course, from the age of 6 months, they will start providing complementary food to children. And this food needs to be safe and needs to be adequate. And this is where you are also needed in an emergency. And that's been the case, for example, in Syria, where from the beginning, because there were not a lot of cases of acute malnutrition, there was not necessarily a big need for setting up treatment of acute malnutrition. It is the case now, unfortunately. But at the real beginning, what was most needed for the Syrian refugees was really to support the mothers to provide appropriate infant and young child feeding. So based on this, Nada and I wanted to share some lesson learned with you. If I manage to get the next slide. So there are obviously a lot of lesson learned that Nada and I could share with you, thousands of them. But we picked 5 for the sake of this webinar. And the first one is the fact that you should remember that different types of crises affect health and nutrition in different ways. So take Syria, for example. In Syria, we didn't have a sharp rise in death rates immediately when the war started to happen. But over time now, after several years of crisis, we are seeing a very large number of deaths over time. And if you compare it with another emergency, such as the Nepal earthquake in 2015, then during this earthquake, the majority of the deaths, they occurred in the first days. So keep in mind that the time window of intervention really varies according to the type of crisis. And we have now evidence because humanitarian aid has been existing for now decades and decades, and we have been managing to gather evidence to show us what are the risk factors that are the most likely to occur and when. And we based on response on those evidences. Another lesson learned that we wanted to share is the fact that epidemics are not necessarily what kills the most. Obviously, epidemic prevention and control remain a priority, but keep in mind that diarrhea, pneumonia, malaria, or neonatal infections must not be neglected. So they need to happen concurrently at the same time, and you shouldn't bring all your resources to the prevention and control in the epidemics. And a very good example to illustrate this is the Ebola crisis in West Africa, which happened in 2014, 2015, and I'm sure you all remember about it. This Ebola crisis, of course, killed directly 11,000 people. But in addition to that, because so many resources were put toward the Ebola response, because the health system were overwhelmed, there were also 10,000 additional deaths that occurred of malaria, HIV, and TB, which wouldn't have occurred if the resources would still have been on strengthening the health system. The third lesson learned is that you can start immediately and then readjust. You don't necessarily need to have the results of a detailed assessment to start your public health intervention. You can very easily start providing shelter, running mobile clinics, protection services, do screening, even before you have all the results of your surveys. And once again, a good example for this would be the current crisis in Nigeria, where last year, INGOs really advocated through the cluster to scale up the intervention and scale up the treatment of acute malnutrition even before the results of the nutrition surveys came up. And then once the results came up, then you would be able to readjust and know in which geographical area you need to provide your resources the most. But of course, for that, you need solid emergency preparedness with trained staff, stock, and budget. A fourth one, not to forget, is that prevention and treatment are equally important. By preventing, of course, you will decrease the degree of exposure and infection and the probability of developing disease, but you won't reduce the risk of death in the people who are already unwell. And if you do treatment alone, then you will very quickly be overburdened because the health system will not be able to cope. So you need to prevent and treat at the same time. And finally, the last lesson learned we wanted to share is to make sure that you have a good coverage in addition to a good effectiveness of your program. And I will give you for that the example of Ethiopia, where we are scaling up interventions due to the drought, making sure that the programs are effective by looking in nutrition at the percentage of children that are cured, for example, but also making sure that all the children that are severely acutely malnourished have access to the treatment so that we also have a good coverage.
Thank you, Alex. And also, in addition, me and Alex put together 8 very practical tips for you to do if you're currently programming in an emergency in health and nutrition. Again, we could have given you tens and tens of them, but we only picked 8, which we think are probably the most important and useful. The first one for you is always be prepared for an emergency. Especially if you work in an area that is prone to natural disasters or a fragile state that is prone to recurrent emergencies like displacement, you have to prepare in advance. You can build preparedness into your current programming. For example, you can approach your donor, negotiate with your donor to have a flexible or contingency budget line in your program budget. A lot of donors actually would say yes if you approach it. They wouldn't offer it, but if you bring it up, they might say yes. Pre-position virtual stocks, pre-position real stocks. Invest in training your staff in emergency response. So there's quite a lot you can do in your current programming to prepare for the eventuality of an emergency. For example, in Somalia at the moment, the health cluster is working on strengthening outbreak emergency and preparedness and response because they feel in the current situation, there are already ongoing outbreak risk of additional outbreaks. They're creating rapid response teams in each region that will be trained and given stock of medicines and supplies. And they will be trained to investigate any alert outbreaks and start ahead of everyone else till additional support arrives. Our next tip for you is to integrate your programming. And by integrate your programming, we talked about the importance of coordinating with other sectors. At the very least, integrate health, nutrition, and WASH programming. At the very least, it's more effective. You can achieve higher coverage as well. For example, in Syria at the moment, nutrition cluster has ensured that all vaccination activities include malnutrition screening. So taking advantage of the opportunity that the vaccinator is there with the child, it's a chance to also screen and refer them for malnutrition if needed. But also delivering nutrition supplements through food assistance channels. And also in Nigeria, the nutrition cluster is working with the food security sector to make sure that families receiving food distribution include families that already have children with malnutrition, children enrolled in malnutrition programs. This is a very good way to increase your coverage and improve the effectiveness and, of course, the outcomes in the affected population. The third tip is to be strategic. When you're planning a response to an emergency, you usually have to make very difficult choices. You almost always can't address all the health and nutrition problems that you see. So you have to be strategic. Prioritize problems that are directly related to the main causes of death. If you're seeing a lot of malnutrition, if you're seeing a lot of newborn illness or maternal illnesses, then prioritize risks that affect these causes of death. But also bear in mind the time in which you are arriving. So there are different risks in different phases of the emergency. If you arrive within days, if you arrive within weeks of the emergency, or if you arrive within months of an emergency, you have to take into account the risk factors that are present at the time you arrive. And finally, work with problems that are feasible for you to manage. Take in mind the security context, the costs, your logistical abilities, and overall, just use your judgment. There isn't an easy formula to prioritize or to be strategic. Use your judgment, and it's very important to document your decision-making process as well. For example, in Yemen at the moment, 50% of deaths are caused by malnutrition and infections and maternal and newborn problems. Another 40% are caused by chronic illnesses like high blood pressure and diabetes. So it's very important that the health sector plan includes things that respond to these top causes of death. Our fourth tip for you is to pause and reflect once in a while. As we said before, the order and the priority of different problems in different phases of emergency changes with time. So once in a while, pause, reflect, am I doing the right thing? Am I responding to the top causes of death and mortality? Is my program still relevant? For example, in Somalia, there have been almost 700,000 people displaced since November because of the famine. And a lot of these people have arrived in existing camps. Now, these camps already have health services running in them. So if you are running a program in these camps, you have to pause for a minute and think, what is this additional influx going to cause? It's overwhelming my health services. There's a lot more overcrowding. What health problems are going to arise? Is my program still relevant? Do I need to adjust? So it's important to take that time to pause and reflect. The next tip is to contextualize your response. So as we mentioned earlier, there's a lot of uniform minimum standards for health and nutrition programming. You almost always need to adapt your programming to fit the local context. Ethiopia, the government has a community health system where there are health extension workers that work with the community. But in South Sudan, there is no such structure. So part of your emergency response, if you are doing community mobilization, you need to adapt it to what resource the community already has. So you would deal differently in Ethiopia than you would in South Sudan because of the difference in community-based resources. The next tip is to coordinate and share. Now, unfortunately, this is still not good enough in most humanitarian response, whether that's through the formal cluster system or even informally. But it rests with each of us to improve coordination. Each of us has a responsibility. Make it a part of your work, make it a part of your job description. If you're unhappy about information sharing in the cluster for any reason, such as security of your assets or your staff, then be vocal about it. There's always ways to share information without compromising the security of your staff or your assets. But also, if you can document your work and publish it, that is also a very important way of sharing information to increase the evidence base for humanitarian programming. The next tip is always think of the invisibles in the population. There's certain groups who have specific needs in every population, and their needs need to be built into the response from the very beginning. And some examples are people living with HIV/AIDS, the elderly, people with disabilities. They have special needs, and it's better to build that into your response from the very beginning. For example, in South Sudan, there are over 9,000 separated, unaccompanied, and missing children. There's all the areas with very high HIV rates have been cut off from treatment. And it's also estimated that up to 250,000 disabled people have been displaced. So the needs of these populations need to be met by making some tweaks and adjustments in your programming. So think about the needs of the disabled when you're repairing a clinic. Think about women who are in their last few weeks or days of pregnancy. Do they have a plan about where they're going to deliver? Think about people living with HIV/AIDS when you do your procurement and programming of medical supplies. And the final tip for you is to be accountable to the communities you're serving. Unfortunately, this is often overlooked in emergency response at the moment, but it's extremely important for the quality and effectiveness of your response. In Yemen last year, a community engagement survey found that 56% of affected people actually don't know where and how to access humanitarian assistance. That's more than half the population. Another 50% feel that their community priorities are unmet, even if there is humanitarian assistance. And so it's important for us to take the extra mile and make sure that that the community priorities are taken into account and that people are informed about how to access humanitarian assistance. Some of the accountability mechanisms that you could do in the health and nutrition sector include obviously involving people at the beginning in terms of determining priorities in the design, but also post-service monitoring. So exit interviews for people leaving a health facility or nutrition facility, having complaint feedback mechanisms. And there's lots of examples. The important thing is to think about accountability, and then there's lots of resources to help you do that in your program. And with that, we end our presentation. Thank you all for your attention. We have one last poll. Right, Alex? We have one last poll, and then we'll take some of your questions.
Okay, thank you for the presentation. I think maybe I will go straight to the questions rather than do the poll, because we have received a lot of questions on the Q&A space. We don't have a lot of time, but I would like really to keep on time because I'm aware that people took 1 hour to follow our webinar. So I'm gonna pick one question for nutrition and one for health. So I'll start with you, Nada. So the first question that came up from the Q&A space was, why do different agencies propose different priorities in health in the same emergencies?
Thank you very much, Ali. Yes, we do see different agencies saying there's different priorities in health priorities in the same emergency.
Nada, I think either there's a problem, maybe you are muted, or because we can't hear you. Okay, sorry.
Is that better? Yeah? Okay. Most of the time, these priorities are not at odds with each other. There usually is more than one priority in an emergency. However, a lot of the agencies have, in addition to the obvious needs, there are different factors that affect their decision making. So they might say something is a priority because this is what they're good at, this is their comfort zone. And also there are ways to present a needs assessment or analysis in a way that highlights a specific set of problems. It's not saying there's not other problems, but it's specifically highlighting problems that the NGO knows it's able to respond to. But also donor interest in a specific intervention many times does result in affecting the prioritization. And finally, the individual biases, the experiences, people's instincts and assumptions also affect prioritization. What we're asking for here is, it's okay to have different priorities if they're backed by evidence. What we want the humanitarian community to be able to do is to have a more objective approach to identifying priorities and accepting that there are usually multiple priorities existing at the same time. And so coordination is very important to make sure that even though people are working on different priorities, they're working together to improve overall health outcomes for the affected population. Over to you.
Thank you, Nada. And I'm gonna, I have picked also one about nutrition. So do we need nutrition interventions in an emergency if the prevalence of acute malnutrition was low before the crisis? Alex, to you.
Thank you, Alexandra. So yes, there are two things to take into consideration here. One is, are we having a rapid onset emergency or a slow onset emergency? If we are rapid onset emergency and the acute malnutrition prevalence was low before the crisis, thinking tsunami in Japan, for example, we might not need nutrition intervention. But if you have a context where acute malnutrition was low before the crisis, I'm again thinking Syria here, and that you know that the crisis is a slow onset crisis and is likely to last, then you need to put in place preventive intervention and nutrition surveillance. So making sure that children are screened and that you monitor the nutrition situation, but also pretty much every emergency will affect the way children under 2 are fed, and especially children under 6 months, and might disrupt breastfeeding practices. So you will, at the very least, need to assess what is happening in infant and young child feeding practices, and make sure that you support the mother to for them to be optimal in responding to the crisis.
Thank you, Alex. I have one quick one that perhaps I should drop just before completing that I just saw. So why is it not allowed to send formula milk to mothers during an emergency?
That's a very good question, because this is something that that affects response very oftenly. So I'll give you the example of the Syrian crisis again, and refugees arriving to the shores of Europe last year, where we had a lot of very well-intentioned people and volunteers who decided to help the refugees arriving by providing mothers with formula milk. The problem is that it's harming the situation and harming the child more than helping the child, because what we need in an emergency, when you have poor sanitation, where the mothers have difficulties in preparing formula milk, where there is overcrowding and children are at risk of getting sick very often from each other, you need them to be supported for breastfeeding at first. So you need to make sure that if you do any intervention, you will first help the mother to restore breastfeeding. And if there is no choice but to provide formula milk, you need to let it done by agencies who know how to tackle it and how to make sure that it's done in a safe way for the mothers. So therefore, by providing formula milk, you might just disrupt the thought of a mother who wanted to breastfeed her child, and then she gets the formula and she decides not to breastfeed the child. And then once the formula milk is over, then she will have no other way but to like try to find a way for the child. The child can get malnourished because she would have stopped breastfeeding. So that's why if there is a need for formula milk, it should only be managed by agencies who know how to tackle the product safely.
Thank you, Alexandra. I'm afraid I will not be able to take any more questions during this session, but I would like to communicate to you that in a few days, we are going to record and repackage the webinar. So it's going to be available online on Kaya, on our learning platform. And I've seen also some requests in the Q&A space about the PPT, having the PPT presentation. But we will also, so that package will include the PPT presentation, this recording, and a PDF document that will include all the questions that were asked in our Q&A space today, where Nada and Alex will give you further answers. So don't worry, we are going to answer to all the questions that have been posted. I also have one message to give you in terms of providing us feedback. So as Jem said at the beginning, this is our first webinar. We would like to have feedback from you. So shortly after the webinar, you're going to receive an email where we are going to ask you for suggestions and ways of improvement. And finally, I would like also to, if you are interested in these two topics and you want to dig deeper, we have, as you can see on the screen, we have various learning packages on Kaya, on the Humanitarian Leadership Academy learning platform. The one you see here are specifically related to our webinar today. So the first that you see is an introduction, effects of emergencies on health and nutrition. And the second one is an advanced guide, always on effects of emergency on health and nutrition. And it is more targeting, it is targeting more technical and professional staff in the health sector. They are available in English, in French, in Arabic, and in Spanish as well. So you're more welcome to dig in and jump into these e-learning resources. And you're most welcome to also consult many other resources that we have on Kaya for health and nutrition. And last but not least, I would really like to thank Alexandra and Nada for sharing their experiences both in health and nutrition. And and I hope and thank everybody that participated to the webinar. Thank you very much, and goodbye to everybody.
Thank you, everyone. Goodbye.
Yeah. Bye.